do that now. We are live. Hello, gorgeous. The very lovely Dr. Rachel Hines has joined us, and you are at the Claire Mellon and Associates at the Portland Hospital, a GP and a menopause specialist. And today we are discussing the International Menopause Society's white paper, which is looking at menopause hormone therapy, as they call it across the pond, of hormone replacement therapy, as we call it here, with 5 W's, which is actually very, from a journalistic point of view, we have a very similar thing when we're writing stories, as who, what, where, when, why, and then we've got a how shoved in at the end. But they very nicely classified and quantified all of this. And before I forget, just let me go over here and click the live on the Instagram as well, which I'm sure will probably, oh my goodness, it has actually worked. Wow, that's but I've still got it here on my phone. So if you're watching on my phone, hello, Elise, lovely, you'll be able to ask questions and I will keep an eye on it. Now, they start off with who. Who is it for? So who is hormone replacement therapy for?
So it's for women experiencing symptoms, like menopausal symptoms, that are affecting their quality of life. So it depends on what the symptoms are and the severity of the symptoms, but it's for women who are being affected by symptoms of menopause.
And in that, some people are going to be a little bit upset by the phrasing, I will say, because it does say distressing, women experiencing distressing vasomotor and vulvovaginal symptoms.
Yeah.
How do we define distressing? When I think of distressing, I think of people on the floor in floods of tears, which might be a little bit much.
So I think that distressing depends on how the symptoms impact you. And everyone experiences a different set of symptoms, and everyone tolerates symptoms in different ways. And what one woman may find really distressing, for example, hot flushes, someone else may not find it that distressing at all. And it just depends on how it's impacting you. If you're having a significant change from your normal self, then I consider that anything along those lines can be distressing. But if you're having any symptoms of any vague significance, really, I think it can be distressing to you, and particularly when you're having a variety of symptoms altogether. So it may be by themselves, none of them are too severe, but actually putting up with hot flushes and not being able to sleep and joint pain and headaches all together, therefore can create quite a distressing combination of symptoms rather than being so severe themselves.
Yeah, absolutely. And I got to mean, it's distressing, I guess, is a small step up from bothersome, which is what we're normally used with. I wish we could have a quantifiable system where we actually sort of say, with the like the pain score, with the little smiley faces from 0 to 10, so you can actually sort of go, yeah, and you can actually rate it. Although, because it just does leave it for, I'm sure there are many women who then will go to their doctor and they're asked, well, is it distressing? And I mean, if somebody said to me, your symptoms distressing, I'd say, well, no, I'm not distressed by them. Yes. And then they'll take the script away from me. So,
yeah, I think it does makes it a bit tricky to be able to say exactly like how distressed are you by your symptoms. But I think if it's significantly impacting your quality of life, then that counts as being distressing, and particularly with vulvovaginal symptoms. So if you're having vaginal dryness, vulval dryness, soreness, all the symptoms that come along with that, then that can be really significant, even if you're not having any other menopausal symptoms. So that's, I think really important to take into account.
Yeah. One of the reasons why they've done this is to sort of address some of the points of confusion that have arisen over the last few years with HRT, just trying to make it sort of very clear for people what they should and what they shouldn't expect and what they should or shouldn't be offered. And one of the things that they say that they're mildly concerned about it being promoted for is that it's being, touted as the elixir of youth.
Yes.
And recently, I don't know whether you've noticed, there's been a lot of discussion about menopause face and the use of estrogen on your face. I hadn't heard that as a term until the other day. Apparently, it's been around for a few years, and I sort of stumbled across this on YouTube. It's like, menopause face, that's me. but
estrogen cream as a moisturizer.
Yeah. So in terms of what do we know that it is good for? What do we think it might be good for, and what potentially down the track may we find it to be good for?
So I mean, essentially what we're trying to not use it for is use it for women that don't have any symptoms. So it's trying to separate out women who are symptomatic. There are other groups of women who we really strongly recommend HRT for. So if you've got premature ovarian insufficiency, so menopause under 40, or early menopause, so menopause between the ages of 40 to 45, we do encourage taking hormone replacement therapy. It helps to protect our bones, so it helps to keep our bones strong, and reduces the risk of developing osteoporosis, thinning of the bones in later life. And we know it protects our heart, so it reduces the risk of coronary heart disease. So particularly for women who are having an earlier menopause and their estrogen levels are dropping, we need to ideally replace the estrogen to help give these preventative, longer-term health condition benefits from it. So that is really important. But I think, like saying an elixir of youth, not some women want to start it for the benefits of taking rather than actually wanting to treat any symptoms from it.
Yeah. Which is it is a tricky one, isn't it? Until we get more sort of proof. I don't know whether or not you watched the interview the other day with Pauline Mackey that I did from
Yes, yeah, it's really good.
What we knew about dementia and things like that. And I think some people got very upset by it because she was saying, well, at the moment we just don't have proof that it prevents dementia, and except for perhaps people with a family history of early Alzheimer's. I think it was the only one that she sort of had a thing. But basically, we just need more studies. And I know people are sort of jumping up and down, going, "But this doctor says that, and this one with a huge following says that, and this, that, and the other." But at the moment, those studies still don't form a complete picture. We don't really have the answer. I think it's quite important for people to understand that.
Yeah, I think particularly in relation to cognition, I don't think there is enough evidence yet. I think there is benefit for younger women, again, certainly a longer term benefit. But otherwise, I think there's so much conflicting evidence that it's really hard to have, a strong standpoint on that. But there are many other benefits from taking it as well, alongside treating symptoms. So it's finding the right balance of what you're treating.
Yeah, absolutely. And speaking of finding balance, what about people who are at high risk, people who have got hormone receptor positive cancers, breast cancer or endometrial cancer in particular?
Yeah.
What's the story with them? Because we hear quite a lot at the moment about people saying, well, you can take it if you want to, it's up to you. How do we know?
So that has to be so hormone replacement therapy has to be personalized to everyone taking it. And this is a really good example of that as a case. And previously it was thought you shouldn't prescribe it at all, but now some women are taking it who've had a hormone positive cancer, who've either taken HRT before or are wanting to start it, but it would be in discussion with their oncologist, their breast team, for example, and with the woman, so that she's aware that there are risks associated. But it's a really careful balance, because if she's got really poor quality of life, she may be aware that yes, it may well increase the risk of your cancer recurring. It may not, we're not quite sure. But for her, it may be a good enough reason to take the therapy because she needs the quality of life rather than having the increased risk. But it really is part of personalisation of therapy. But you would do that as part of a multidisciplinary team usually, in terms of making the decisions relating to it.
Yeah, very difficult decisions to make. In terms of the next thing they get to, apart from the who, and then they move on to the what. Yeah. So there are a variety of different types of hormone therapies. Yeah. What have we got, and does it matter which ones we take?
So again, this is part of the personalization of therapy. So it depends on what you need to look at is the person and what your own personal medical history is, what risk factors you may have. Also other factors like what your weight is, so if you're overweight, if you smoke, and what you need to think if you take, so when you take estrogen, so you need estrogen to treat your symptoms. And if you have a uterus, you need to have progesterone as well. And for the estrogen, it can be taken orally. You can take it as a tablet. That slightly increases the risk of blood clot. So if you are at an increased risk of blood clot, for example, you've got a higher BMI, or if you smoke, or have migraines with aura, then you would think about having HRT through the skin so that you don't have the risk of clot. And then the different options of having it through the skin is, again, then personal preference. So whether you would want to have it as a patch or a spray or a gel. And then you need progesterone to go alongside it. And again, the choice of the progesterone does impact, and there are different risks associated with different types of progesterones. So it's looking at your history and what's most suitable for you to take.
Yeah. In terms of those progesterone different variations, I mean, basically, some are more androgenic, some are less androgenic. Are there factors then that you would take into account in terms of, say, people's history of heart disease, metabolic diseases, those kinds of things that would make you sway towards one over the other?
Yeah, absolutely. And looking what their symptoms are and looking at your weight, if there's any history of polycystic ovarian syndrome as well, and looking at what would be the best really for them to try. And also it's thought with the body identical progestogens, so like utrogestan, that it's thought to have a lower risk of breast cancer. So particularly if you may be at an increased risk, that's something that you would consider. And so it's looking partly at what your history is, partly what your symptoms are in terms of what you pick to go with it. And with the estrogens, there are different types. The one we use most commonly at the moment is called estradiol. So that's a body identical estrogen, so the same structure as your natural hormones, but that's used most widely. There is a new type of estrogen available in a combined contraceptive pill called estetrol, which is an end product. It doesn't get broken down to anything else. And the white paper is saying it's likely to become available as part of HRT as well, which would be really exciting if that was to become available.
Yes, and it seems to be for GSM as well, for your genitourinary syndrome of menopause, which just rolls off everybody's tongue.
Yeah, so yeah, absolutely. Yeah, so it looks, so there are new developments, new sort of products coming, and then we use different types of estrogens vaginally as well. So it's again that can depend on what your personal history is in relation to that.
There are, I mean, you mentioned there are different types. Like there are 4 of them. There's in the bioidentical world, the compounded world.
Yes.
There's quite a bit of an argument saying, well, we need all 4 of them. Is there any evidence to back that up that we do need all 4?
No, there isn't. So there isn't enough evidence to back that. So I know certainly there will be different combinations given of the different types of estrogens, but no, there isn't enough evidence to say that you need that, and therefore one type is enough for treating in the sort of conventional sense of treatment anyway.
Yeah. Now, the other thing that comes the sort of slightly controversial area, I suppose, is the dose. Which is, there's been a lot of discussion about doses recently, which we probably won't necessarily go into. But are there some types of people that do require higher doses, and who would they normally be?
So there definitely are, and everyone absorbs differently. So especially if you're having it through the skin. So a gel, a patch, a spray, we all do absorb differently. And some women will need a higher dose of the same to absorb it. And there's lots of different factors, and including sort of medication you're taking, if you smoke, if you've had any alcohol, what the temperature's like, the time of day. So there are lots of different factors that can affect absorption. And for some women, they do need higher doses because they just don't seem to absorb in the same way. Most women should be able to take oral estrogen, but not everyone. And so if you're not able to take it orally and you can only have it through the skin and you're not getting this sort of symptom relief, and we can check estradiol levels, they're not necessarily so accurate, but they do give you an idea of what the absorption's like. And so sometimes we do need to go up, but if you are going higher, then women need to be aware that they are being given a higher dose.
Yeah. The thing that I didn't know this apparently, but apparently you absorb estrogen better in the evening.
Yes.
According to this paper. I did not know that. Yeah. So if you're on a patch, obviously it's a continuous sort of use, but if you're a poor absorber, then is it better perhaps then to swap to a gel and use it in the evening?
You can try different times of day for using it, and sometimes splitting the dose can be helpful, especially to say if you're using a gel when you go above 2 pumps, it can be useful to split the dose morning and evening. And if you're not, so if you're using a patch or a gel, because then it can often maintain the levels rather than having it going up and down. So some women do respond really well to that. It can be quite stimulating estrogen. So sometimes women find if they take it in the evening, it can affect them sleeping. Other women, it doesn't affect them. So again, it is down to the individual. But yes, you can try it in different ways.
Yeah.
And you might find it's better.
I'm guessing also, I mean, you mentioned smoking there, and stress is another one they mentioned as well. So that because it all affects the way the blood vessels on the surface of the skin. Is this the sort of underlying, which I guess is also when some people say, well, if you want to put it on, make sure your skin's warm, give it a bit of a rub, and get that sort of blood flow going.
Yeah.
Are they like little hacks that might help?
I think things that are really important is always how you're using the product that you are. So sometimes women will put gel on and just get dressed straight away. So it doesn't, you've got to get, so if you're using a gel or a spray, you have to give it time to absorb. If you're putting a patch on, it's good for your skin to be at room temperature. So if you've had a shower, wait for your skin to cool down. You can give the patch a little rub before to warm it up. And then when you put it on the skin, again, then just like rub it to stick it on. Don't put body lotion on before. So there's lots of different, and with the gels and the sprays, you shouldn't get it wet for an hour after. So there's quite a few different tips in relation to how you're using the product to make sure it's absorbing well as well.
Yeah, here's an interesting thing. I mean, okay, if you're using the gel now, for example, I rub it between. I do the no hands approach. So I put it between my thighs, and luckily I don't have a thigh gap. So I give them a nice sort of rub together. But 20, 30 minutes later, they're still sticky. If it's sticky, does that mean that I can't get dressed?
So you shouldn't be able to feel it, ideally. So once it's on, so it might be worth putting it on your arms as well. So if there's too much, then it doesn't really absorb. So if you can still feel the stickiness, then I would assume that it hasn't been fully absorbed yet.
I have a little hack too, actually, from I went to an event run by the Skin Diary a few weeks back, which is a new prescription level skin grade service. Yes. And they had a bunch of sort of experts in various areas talking, and one of them was on formulations. So she was a formulator at UCL, I think, or King's or somewhere. And she was saying for HRT, if you're using the gels, try to apply it in the same spot, not just because you're sort of making this reservoir under the skin, but because not all of it goes through the first time. But once you put the alcohol, because they're in an alcohol base, once you put the alcohol back on top, it will also release what was stuck in the residual on your skin afterwards.
That's interesting.
I hadn't heard that either. I thought, well, that's an interesting little tidbit. So there you go. I love a little interesting tidbit.
Yeah, that's really good to know. And yeah, but particularly like you said, especially if you're using the spray, trying to put it on in the same place is important. And apparently near your knees, if you're putting it on your inner thigh, lower down near your knee is better for absorption.
Oh, is it?
Yeah, with the spray anyway.
Well, that's interesting, because I would have thought sort of up the top where you've got the fattier bits. Really, I'm only talking about my own thighs here.
Apparently, that's the best. Also, I've been advised, but that's the best. If you're using the spray on your legs, the lower, like just above your knees, inner thigh is the best bit to put it.
There you go. Two questions. One first, while we're talking about the spray, I'll go to that one first. Are people having to use more off-license dosage of Lenzetto to increase levels? Because that's got a lower maximum. Is it 3 sprays, I think?
Yes. So 3 sprays of Lenzetto is equivalent to 2 pumps of gel or a 50 microgram patch. But it is only licensed for use up to 3 sprays. We do go up to 6 sprays of it. It is in the new BMS unscheduled bleeding guidelines. They have up to 6 sprays in it. But yeah, 4, 5, and 6 are off-license uses of it. But it's safe to use, but being aware that it is an off-license use, even though it's an equivalent dose of the others.
There you go. All right. And going back to the cancer, I have a question over here asking, what do you do if your cancer team says no to HRT and you want to take the topical estrogen cream? She had a womb cancer and radical hysterectomy 6 months ago. I mean, we know that there's very little absorption of the vaginal estrogen.
For the vaginal estrogen, generally that's safe to use, and there are different types that have a lower concentration. So the Invagis pessaries and the Blissell gel are a lower concentration of vaginal estrogen, and it's usually considered that it's usually okay to use, but it does depend on the individual case. So it's really hard to comment, I'm afraid.
Yeah. So maybe going back and suggesting one of those other ones, or
just using a lower dose of it.
Yeah. For cancer patients, I think, especially if vaginal dryness is not fun.
It's a really significant problem, particularly for women that have been treated for cancer. It can be really difficult to manage. But I can't say it shouldn't be a no, but it does depend on what the details are in relation to it, I'm afraid.
Yeah. And is there a period after which you've had a hysterectomy and those things where before you'd be regarded as clear? How long is it until you're given the sort of the green light to be sort of all clear?
Again, it just depends on what the cancer's been, what treatment's needed around it. So it's quite variable.
Yeah. The other thing I guess about that then is using non-hormonal alternatives.
Yeah.
And there's a lot of stuff on the market, but gee, a lot of it's got some nasty stuff in it.
Yeah, so there's non-hormonal. The other hormonal thing to consider as a potential option is something called prasterone, a vaginal pessary, which is it's made of DHEA, which is a precursor to testosterone, but can also be really good for vaginal symptoms and is an alternative, which again, asking your team to consider as well as a vaginal estrogen, but using the vaginal prasterone is another option. And for non-hormonal, yes, so like vaginal moisturizers can be really helpful. Also, good vulval skincare is really important, and using non-perfumed products, using good moisturizers, not using the heavily fragrance products, completely avoiding. There's a really good leaflet or patient information leaflet on the British Association of Dermatologists. It's called BAD, but it's called Care of Vulval Skin, and it's really, really helpful. But that is important, because then if you're washing with a moisturizer and applying a moisturizer to the vulva as well, can be a really helpful thing in addition to whatever other treatment you're using.
Yeah, yeah. Very, very tricky one. You also mentioned oral estrogen then. Now, when people think of oral estrogen, they normally think of the conjugated equine
Yes.
CEE one that was, used in all of the studies sort of way back where we all go, oh. But there's also a body identical one now that comes with a progesterone. What do we know about the safety of that in terms of, because the older ones, they sort of worry a bit because it goes through the liver and greater risk of clots and those kinds of things. Does the same apply to the body identical one?
It does, but it's thought, I think there is still a clot risk, but it is less. So Bijuva is a combined estradiol and body identical progesterone tablet that you take, the postmenopausal women take. So if it's a year after your last period, and it's a combined oral HRT. So it's the only body identical HRT there is, and it's thought to still, there is a clot risk, but it's lower. But if you're not at increased clot risk, it should be safe to take oral HRT. I think at the moment it feels very much that there's a very strong feeling that most women want to have it transdermally, so to have it through the skin. But oral preparations are good, and combination ones particularly. So
it's funny. I met up with a friend actually from Australia last week who was over here, and we were talking about HRT, and she said, "I'm on Bijuva," and I looked at it, was like, "Oh my god, you're the first person I've ever met who is." It doesn't seem to be particularly widely prescribed.
Yeah, and I mean, it's a really good product. It is a really good product, but I don't have many women on it. I think generally most people do seem to want to take it transdermally, but it's a really good option. I think also because there isn't a perimenopausal option for it. It's only for when your periods have stopped, so it's a continuous HRT. So all the tablets have got progesterone in, and so therefore it's something that would be started a bit later, which may be why it's not used so much.
Maybe, although interestingly, she's 58. She's still having her periods, which was another first for me to meet somebody that old. I was like, really?
Yeah.
Not that much younger than me. Anyway, there you go. The other thing the paper mentions that might throw people into a bit of a fit of, oh my God, what is this? Is it says the risk, if you're on high doses, there's a risk of a thing called tachyphylaxis.
Yeah.
What is that, and should people worry about it? And how
So
rare?
it's not very common, and it's when you've got really high doses of estradiol, so when your estradiol levels are really, really high, and it can cause really quite significant anxiety and palpitations. So the levels are too high, which is a reason for when you're like going up slowly with estrogen doses. So when you're using HRT, not going up too quickly, to try and avoid side effects and avoid tachyphylaxis, but it's not common. So it's not something to worry about, but it's something to be mindful of if you were previously feeling well. If you've had a dose change and you're starting to feel really anxious, or you are getting palpitations a lot, it's definitely something to consider. So it's really useful to be aware of it, but not something to worry about, I would suggest.
There we go. Good. Now, the other thing that it tackles, this paper, is the when, which is also an interesting one, because when to start, when to stop, those kinds of questions. So how early do we start? How late is it to start? What are we going on there?
So most of the evidence is in relation to being postmenopausal. How early you should be starting views it does vary. Particularly, as I said, women with POI and early menopause should be starting it early. And then you take it, so the average age of menopause in the UK is 51, and you'd certainly take it until then. The average age of menopause globally, in the white paper, it says it's 48.8, so where it would fall, but in the UK it's up to 51. And for those women, you encourage them to start it early. Otherwise, it depends on symptoms, at what point you would start it. You can, in sort of particularly in early perimenopause, you can consider whether to have a combined oral contraceptive pill can be really helpful, because then you're reintroducing some estrogen in that way rather than needing to take HRT. So it's kind of working out how the severity of symptoms and the impact as to where you start it. In terms of stopping, there isn't an endpoint. There is no kind of arbitrary length of time at which you should take it for. So it's kind of thought you should take the lowest effective dose for the shortest time possible, but that might be 10 years. It completely varies. But so previously we used to give it for 5 years, whereas now we're giving it for much longer. And it just depends on individual symptoms and age of menopause and factors around that.
If you are sort of heading into that sort of 10 years plus, or you're over 60, is there at any point people will probably start to think, oh, maybe you should start tapering down because your symptoms are disappearing? Is there actually any evidence to support that?
So it's once reaching 60, by the age of 60, usually we'd be able to reduce the dose down. And if you were on oral HRT, we'd want to switch you to having it transdermally through the skin, because the clot risk does increase with age and stroke risk increases with age. So therefore, you would want to be on a product that's not going to increase that risk for you. And it's likely that you're not going to need as high a dose at that length of time, because your natural estrogen levels will have come down, and it's unlikely you will need as much. Some women who have persistent vasomotor symptoms, whose hot flushes and night sweats don't go away, may end up needing it to be a higher dose and for longer. So it depends. But usually you're able to, if you're still taking it at that point, we reduce the dose down. Yeah. Usually, right? If you reduce down, your symptoms come back, you'd go up again, but often you're not needing as much by then.
And the other the other question is, if you are over 60 and say you've got a diagnosis of osteoporosis, or you are having symptoms and you never started in the beginning, is it safe to start, or are there things that, what are the risk factors and how would you know?
So again, it's looking at what their personal history is. If, if their blood pressure is well controlled, so you'd be thinking about things like blood pressure. Do they have any heart disease already? What else is going on? But you would start it transdermally. If you were to start it, it would be through the skin and at a low dose. And to see what you need, because you may not need a particularly high dose to help control symptoms, but you do need to be taking quite careful consideration into what else is going on in their health. But it doesn't mean you can't stop it at that point. And we know in terms of benefits that if you start it within 10 years of your last period, you get the protective benefits for the heart and reducing the risk of heart disease, and it helps maintain the bone density. And so particularly if you do have osteoporosis, then introducing HRT is going to help maintain the bone density and stop it falling further. So there's really significant benefits from taking it, balancing it against whatever their natural risk is going to be.
Yeah. Which brings us to the why is it important, which is the another YW in there. And it's actually because they run through a lot of other sorts of symptoms for why you'd want to take it. You mentioned before sleep, and the other one was the musculoskeletal joint pain. And we now have the floating of the concept of the musculoskeletal syndrome of menopause. And this being a quite significant symptom that has, I remember myself going to the doctor and saying, my knuckles are aching, and, being sent off for all sorts of blood tests to see if it was arthritis and God only knows what else. If people are rocking up to the GP and saying, well, I may not actually having incredibly distressing, and if you just joined now and you're thinking, why am I going distressing? Go back to the beginning of this talk. Distressing vasomotor symptoms, but I've got really poor sleep, and I've got incredible joint pain, and my muscles are aching, and I'm feeling tired all the time. Are these things that can now be considered as reasons for starting?
Well, we know certainly that there's now sort of increasing evidence that if you're having significant vasomotor symptoms, so hot flushes and night sweats, that it's associated with an increased risk of cardiovascular disease. So therefore, it's important to treat the symptoms, because we don't know if it's causal. So you don't know if the vasomotor symptoms are the causal factor to increase the risk. But certainly you'd be wanting to treat the symptoms because of that association. So it is important to treat the symptoms that you're having. And in terms of benefits, if you're thinking about why it's important, well, if it helps maintain your bone density, so it helps reduce the risk of fracture, helps reduce the risk of osteoporosis, That's really important. And it reduces the risk of heart disease and bowel cancer, type 2 diabetes. So there's lots and lots of benefits of taking it, and the long-term preventative health impact for women who are symptomatic. There are lots of benefits from having it.
Yeah, yeah. The other thing they mentioned though is setting realistic goals. And there seems to be this sort of perception that, if I start HRT, I'm going to go back to being the same woman I was when I was 35.
Yeah.
Can it get rid of all of those joint pains? Will it get rid of all of that brain fog? What's a realistic expectation, really?
I think it's usually, so it's knowing how often you should be reviewed and knowing what to expect. And so it can take up to 3 months to notice an improvement in your symptoms. So if at 3 months, you should be reviewed every 3 months after you have a dose change. And if there is no improvement or no change, you need to have a think about what symptoms you're having. So if you're still having really persistent joint pain or redness or swelling of joints, thinking, could it be rheumatoid arthritis? Could there be something else that's causing the symptoms that you're having? So we need to think about, if symptoms aren't improving, why they're not. Do you need to do bloods for other conditions? Do you need to make sure you're absorbing? So it's kind of expecting it might take up to 3 months. And even if your friends got better in 3 days, your symptoms may not. And so it's having a realistic expectation of that and making sure women know what they're using, how they're using it, and what to expect. And also to know what side effects can happen as well, which can occur alongside. So it's getting realistic expectations of what, but you should get back to feeling your usual self normally. Like, you should be treating the symptoms, they should go with it.
Yeah, I suppose in some ways it's also, while I am the first person to say I'm not taking aging lightly and I'm not taking it lying down, also there are some sorts of things where you just kind of think, well, actually, I am 60 now. How much of this is just actually really where I should be at this age?
Yeah.
How much of it is, because I guess, things change over time too. You find that, you are getting more tired, or you are, it isn't as easy to do X as it was before.
Yeah.
So I guess you've got to sort of balance how much it can't keep you feeling 35 forever, surely.
No, and I think lifestyle is so important at this stage of life as well. And it's just, it's highlighted in the white paper, but it's just a really good opportunity to evaluate what you're doing and what improvements can you make. And if you're not sleeping, is there anything else that might be contributing to it? For example, if you're not exercising, looking at how you can bring that in, because that does help with managing symptoms. And if you take HRT and make no other changes, and there are changes that can be made, it's not necessarily going to fix everything. So it is working out what's going to work the best. If you're drinking lots, your sleep's not going to be good, your anxiety might be high, you may not be able to concentrate. So if you make improvements like that, and it's doing it together, it's not just HRT. You do really need to focus on lifestyle as well.
Yeah, absolutely. As people say, no amount of HRT is going to fix a bad lifestyle. And the people often get they say, I was sent for this and I was sent for that and I was sent for these tests and all, and what an incredible waste. But it also is incredibly important to rule things out, isn't it? Like vasomotor, like night sweats can be a symptom of high blood pressure. So it's very important to rule things out as well as rule them in.
Yeah, and it's a good, so as part, whenever you're starting HRT, when you're reviewing, you check blood pressure, and it's a really good opportunity to review your cardiovascular health. It's like you check blood pressure, you check weights, you know what your body mass index is. You have a think about, have you had your cholesterol checked? Do you know what if you're diabetic? And so it's a really good opportunity to be kind of.
I am smiling here, by the way, because not with my GP. But anyway, there you go. Yes. Anyway, yes, these are good ideas. And actually, there's quite a number of calls coming now for a health check at 50. It came up in the Australian Senate inquiry into menopause. I think it's also, if you read I can't remember, it's actually in this full white paper as well, but basically saying when you go through menopause, to actually come in and have that check, get your blood pressure reviewed, get your lipids done, get your blood sugar done, get all of those sorts of things, get a baseline, and just make sure you're really on top of them.
Yeah, it is offered here in the NHS. It's offered if you're over 40, but I think if you're not necessarily going to be at the same time as going, I think time dependent really. But yeah, it's important. It's important in midlife to be aware of these factors, because we are starting to develop high blood pressure and high cholesterol, and it's a really good opportunity to be able to identify it and reduce your risk.
Yeah, absolutely. It is a big, important thing to do, because as we know, biggest killers of women: heart disease, dementia, those kinds of things. So, and they're so affected by these factors.
Yeah, and
Yeah.
lifestyle really does help. Like,
Yeah.
it really does. So it's a good opportunity when you're doing sort of menopause consultations to discuss lifestyle and how you can improve that alongside as well.
Yeah, exactly. Now, the last one is a kind of a political question in a way, really, isn't it? Because it talks about where hormone replacement therapy or menopause hormone therapy, depending on where you are, can be accessed. And, you know, in some countries in the world, basically, there is zero access. They're not even thinking about it. But here, even, it's a postcode lottery. So we have a question then of how we even this out and improve access, even in the UK, for people where they can't find where. And Lana, I'll come to your question over here in a second. Is where basically they're being told, well, that's not on our formulary. You can't have it. How do we get around that to make sure that this is equitable and fair for all people going through menopause?
It's really hard to answer that because, exactly as you say, it does depend on where you are. So in terms of body identical now, you should be, as far as I'm aware, you should be able to get body identical hormones, and it's like usual, like HRTs with synthetic progesterone and body identical progesterone. I know it was licensed in Scotland relatively recently, but as far as I'm aware, you should be able to get it all over now. But I guess it just depends on different areas that what their medicines management are allowing. If it's on the NHS, what you can have. Certainly until very recently, the Prasterone pessaries, intrarosa, were only available privately. I think you can now get them in some places on the NHS. Certainly testosterone is a really controversial area, and the only licensed product for women isn't British anyway, it's Australian, but you can only get that privately in the UK. It's not, at some point it will become available on the NHS, but not yet. So in terms of equity, that's not there in that area. But yeah, it is. Yeah, I think it should be a bit more balanced, but I think it really does vary.
It's just something I just don't understand. I don't understand why we need for every 200,000 people or so a different formulary that, you know, I don't understand why there isn't one national one. I mean, that must just cost a fortune to administer for a start.
Yeah, probably.
And why it's different. The Lana's question over here is actually saying she's noticed a few people saying that they're now getting refused testosterone from their GPs, even when it's been previously prescribed. Has something happened? Has there been any change in testosterone guidelines? Not that I've heard of.
Not that I know, but again, that really varies from area to area. So some areas you can have it, and it can be the neighbouring borough that you can't have it prescribed, and you end up having to go to secondary care clinics to get testosterone, which I don't think is a very sensible use of anyone's time, especially once you're stable. Once you're stable on testosterone, you need your bloods checking once a year, and you keep an eye out for side effects. But that really does vary. But I know I think lots of doctors don't necessarily feel confident to prescribe testosterone or haven't done additional training for testosterone therapy. But yeah, that is in some areas it is really restricted. You just cannot get it in general practice. So there can be huge waits. You might wait for a year to go to a menopause clinic to get some.
Yeah, exactly.
And that's really difficult. But
yeah, you're thinking, you know, if you've had it previously and you've had no problems, what on earth would be the logic behind that?
I can only imagine it's down to individual areas and what their different sort of guidelines are in relation to prescribing. But we do have guidelines for testosterone, so it should be quite straightforward for use.
Yeah. One question here from Joe asking you, what's your opinion on low-dose HRT if you've had a DCIS 10 years ago? Fortunately, she's had limited menopause symptoms, but interested in other areas you mentioned with, you know, bone density and heart disease, especially because we know that there's an increased risk of heart disease with people who've had cancer. So is there 10 years on? What do we think?
Again, it's in terms of how you interpret risk. So if you're reintroducing estrogen, it may well increase the risk of breast cancer. And so it would depend on what the symptoms are that you're having, the other details in relation to the cancer, and whether it would be in discussion with the team if you're still under their care, or contacting them to say what would their thoughts be in relation to it. But so if you weren't necessarily so symptomatic, whether it would be worth introducing an additional risk for preventative health factors, it's a tricky balance. So, but you'd need a bit more information to be able to work that out.
Yeah, interesting one. The and in terms of access, I mean, you mentioned before that a lot of GPs aren't very confident in prescribing testosterone or hormone replacement therapy in general, which I think is why we have a lot of difficulty for a lot of women in some areas, which leads me to say we are about to do the Menopause Research and Education Fund, our third full day of education for GPs
Right.
and allied healthcare professionals. So if anybody knows anybody who they think would benefit from that, your pharmacist, if they don't know what they're talking about, your GP, if they're having difficulty, then this runs through everything from the very, very basics of, what is menopause and how do I identify it, to prescribing testosterone, to managing PMS and PMDD, to unscheduled bleeding, right through to very, very complicated things such as cancer and endometriosis and fibroids and all of that kind of stuff. So if anybody knows anybody who they think would benefit from that, send them to, it's 15 quid for the whole day, presented by BMS accredited menopause specialists, overseen by Vikram Talalika from UCL. So it is a very, very comprehensive day, and you can do it at your leisure as well, because the recording, you don't even have to sit there for the whole day. So
no, right. I think because we didn't, as GPs, we didn't used to prescribe HRT very much at all, because following the WHI studies, so many women stopped taking HRT, and there really was about 15 years where you just didn't really prescribe. Like very, very few women took it, and then the NICE guidelines kind of made women more confident, made doctors more confident again, and it started to gradually increase. And in the last probably 3 or 4 years, it has just, so many more women are taking it now, which is great. But I think it takes time for it all to catch up.
Yeah.
True.
Yeah,
great.
Brilliant. Is there anything else we need to mention over the 5 W's from the IMS in their paper, or do we think we've covered it?
I think probably covered it. I think essentially is the reason that they're doing the paper is just to kind of provide a kind of blueprint and reassurance, and get a kind of, I don't know, a bit of equity across prescribing, ideally, so that we're all doing the same kind of work.
Yeah, absolutely, which is a good thing.
Yes.
Brilliant. Well, thank you so much for your time. So if people want to find you, where do they find you? At the Claire Mellon?
I'm at Miss Claire Mellon and Associates at the Portland Hospital, so in London.
Yes, and on Instagram, where do they find you?
At Dr Rachel Hines.
Dr. That's very easy then.
Excellent. Yeah. Nice and easy.
Exactly. Brilliant. All right, let me end this one over there. And I shall end this one over here as well. So look, thank you so much, and we will speak again at another stage.
Lovely. Thank you very much.
Bye.
Bye-bye.